Okay.
All right, well,
Well,
it's the top of the hour, guys. I think we
all
probably
right.
Alrighty.
start. I think we're going to have a smaller group because we had screwed up on times and dates this time. But we'll go ahead and start, and I'll just reintroduce ourselves. We're the Audio-Vestibular Medicine Case Discussions Group, and we're doing monthly uh, monthly presentations on interesting audio-vestibular medicine cases. The hosts are myself, Gerard Gianoli, Mohamed Hamid, Eugen Ionescu, and but everybody's encouraged to participate. And I just found out we'll have a new presenter next month. Hopefully, Art Mallinson will present for us. Just a note, the information discussed is meant solely for educational purposes and not intended as medical advice for any individual. For individual medical advice, please seek the counsel of your physician. While the conferences are geared toward medical professionals, patients are welcome. However, we will not discuss individual patient cases in this setting. Please speak to your own physician for individualized medical care. And as we've mentioned before, we memorialize these discussions on our YouTube website, and the address is listed right there, youtube.com/@avm case discussions. And so at this point, I'm going to turn things over to Eugen Ionescu, who's doing the case presentation this month when it looks like Meniere's, but it's not. And so, Eugene, do you have can you share us
Yeah.
the slides, or do you want me to put up your slides?
No, if you can, I sent you an ask to for
Okay.
this for to get sharing the my screen. Okay.
All right, here we go. I'm gonna,
So
and
yeah,
let's see.
just a second,
And
just a sec, because you may I share the screen?
yes,
There
go
we
ahead.
go. Looks great.
Okay.
I think I have to stop sharing first, huh? Do I?
Yeah.
Stop
Yeah.
share. There we go.
And now I think that it might be okay. Okay. You see my screen now,
Yes,
everyone?
Yep.
sir. Here it is.
Okay. So it will be an pretty nice case, which I and my colleague Pierre Renard, we just have to dial now 8 years ago. And I think that, yes, and I think that I put it at the end of the presentation that we have published already this case. So it was about 73 years old female which is present in the emergency room for dizziness and headache in some times in sometime in 2015. Uh, she lives with her husband and one disabled child, and she progressive developed rotatory vertigo and occipital pulsatile headache, which was not habitual. She was not a migrainous person. So the initial clinical examination, there was no neural signs, no focal deficit, no meningeal signs, and there was a right horizontal rotatory nystagmus, and some auditory impairment, but there was not performed an audiogram at that time. The Romberg was positive non-systematically. So there was no neurological sign, no cervical abnormality. Uh,
Eugene,
yeah,
can I ask a question?
yeah.
When she was having the rotary vertigo spells, how long were they lasting, or was it just one continuous 15-day episode?
No, that was intermittent, more likely. But the auditory sign was not present uh, there was present only from time to time, not associated systematically with the vertigo spelling.
I just want to
Was
make
it?
a quick I just want to make a quick comment there. That's an extremely important question Jerry just asked. Some patients will come in and say, I had vertigo for 15 days. So you write down 15 days constant vertigo. But the patient actually means they had a 15-day period during which they had repeated spells lasting 5 minutes each, 8 times a day or something. So it is so important to delineate that. And I mean, you have Eugene, and it's very important to remember
Yeah.
that. Totally
Yes,
different
this is.
kettle of fish.
It's systematically we must ask our patient if they are some if they have some headache before cephalea, posterior cephalea, to see that the systematically there is or no auditory signs, what kind of signs, as if these signs are accentuated.
Uh-oh.
Uh, yeah.
Eugene, we lost your voice.
Out my
Yeah.
voice.
Oh,
It's
there
Yeah.
you
now
go.
now
Yeah.
okay.
Thank
Hello.
you. Yeah.
Sorry.
This is a very important point. When people call and I've been having vertigo, there has to be a way of objectifying it. And I ask the family members to actually take pictures or a video of
Yeah.
their eye and head movements because this is very critical and very important.
Yes, you're right, but this was the point where the patient was to go to the emergency room, and they had no general instruction from their medical generalist, the treat whatever the practitioner, general practitioner to enregistrate or uh, to have some more evidence, video or photo to have to present to the specialist. It's very rare, but I think that we must develop these techniques when we see successively and we follow up in the follow up of the patient. We need to use video registration. I already use it from now more than 7 or even 7 years ago.
Yeah.
So it's very important. So, but we came to the, I came back to the presentation, and
I
the
want
patient.
I want to
Yeah.
introduce you to Bulent Mamakoglu, who is a good friend and colleague from New York, who's got a question for you.
Okay. Please.
Hello all. That's the first time
Hello.
I was able
I
to
believe.
do it. Hello. What do you? That's a new term for me. So would you explain me what is occipital pulsatile headaches? What's
It's
that?
a cephalea. Yes, maybe it's more French expression, but
Oh,
it's
okay.
a headache, pulsatory headache posteriorly on the occipital region.
Occipital region. All right. So this is different headaches than she used to have.
Um, Headache, I may, but yes, I will say that is an expression which might be an headache, posterior headache, and pulsatile. I may make a little bit difference between an neuralgic tip of algia of the posterior um, um, and the posterior region occipital. You know that when I say headache, it's like a constrictive algia, but pulsatile at the same time. So in this case, what was maybe important to do a different diagnosis between eventual and posterior migraine, vertebrobasilar migraine, and other headache cephalea. So this why, and generally in emergency room, the doctors will think to should eliminate a stroke,
Hmm.
and in this case, they perform only TDM and cerebral initially a cerebral scanner, and they didn't perform in the first time. Secondly, they didn't perform an MRI. Even thought they were demanded an MRI. But as you seen here, we can observe only an later cortical atrophy. This not, it was a CT, this was not an MRI, sorry. This was spelling here. And some supratentorial leukoariosis and diffuse cortical and supracortical atrophy, no acute ischemia, etc., and the cervical spine intact. So they concluded that this patient should be referred to ANT for an eventually differential diagnosis, but they excluded a neurologic problem. Ulteriorly, the patient didn't refer to the ENT. She became more or less progressively not symptomatic. But she came back in the emergency room and she started to worsen to present again symptoms in 2017. And from time to time, his general medical doctor prescribed him to beta-histine, which is a medicine which is used very much in France in case of Meniere disease or vestibular problems, even if the diagnosis is not very well detailed. And in this case, she presented this time, she described a very intensive right tinnitus, ear fullness, and but when compared, yeah, there were some two audiograms which showed that the auditory that the hearing is not impaired, that not fluctuating in time. However, the emergency room is they suspected a Meniere disease on the right ear, and again they prescribed beta-histine, but they added in Diamox, but not relief immediately 2 weeks after. So in this case, finally, the patient was referred to an ENT specialist, and as you can see here, this was the audiogram. At this point, what are your could be your feelings in this case of this asymmetric neurosensorial hearing impairment? Did you have some observation when looking to the pure tone audiogram and the intelligibility?
Well, I mean, did she have a previous audiogram? Clearly, she has right hearing loss. I'm not quite sure if the bone is
Yes, the
there.
bones, it's still, they were at the same time. There was no conduction hearing loss.
Okay, all right.
But I'm not sure that they performed very well the masking on the bone conduction.
What was your tuning fork test on this patient in the office?
They were lateralized to the left side.
To the left side. Okay, so she has a sensorineural hearing loss on the right. Speech discrimination is not there. And tympanometry.
There was not available. They did not practice.
Yeah. No, I think the speech discrimination is there on the top graph, isn't it?
I think that's it. Yeah.
Yeah.
I would
pretty poor on the right.
Reiterate a point Mohamed was just making. When I see audiometry and there's no bone scores, it immediately gives me a bad feeling in the gut, because I don't know if you got a conductive gap. You don't know if you got crossover from the other ear. We may be dealing with a completely deaf ear here.
Yes.
That's just getting crossed
And
over to the left side.
you are all right. Besides, if you look in the left, they put it at 1000 hertz. Weber was indifferent, tuning forks, with the tuning fork. That's very confusing. It's not a very good audiogram, but that's what I found.
But let's assume for, like you said, that the bone scores are in line with the air scores, that we're dealing with a severe sensory neural loss that looks pretty flat. I think and it looks like you've got reduced discrim. So reduced discrimination, you got to wonder about a retrocochlear pathology, because that's the classic presentation.
Yeah.
Although a Meniere's type pattern is not as common, so you got to think about some other things as well. But going back to the original presentation, I think if that really was a 15-day episode of just continuous vertigo, you got to think of a really big event, and then now she's getting small events afterwards, like a labyrinthitis or a vestibular neuritis or what have you that could have now morphed into something different.
I think so far I wouldn't make a diagnosis of Meniere's disease without evidence of fluctuating hearing loss.
Yeah, yeah, but yes, in as a matter of fact, she had on she had only sometimes vertigo spelling, but there was not continuously. They may be aggravated from some position when we get back to have the history, the patient correctly, we realize that she had more like some from time to times vertigo constantly of some peaks of vertigo, but and classically, as in Meniere disease, as in Meniere disease, some pressure in the right ear.
I would, agree with Mo that I wouldn't make the diagnosis of Meniere's disease per se, in that I'm reluctant to make that diagnosis until I've excluded all kinds of other
Everything.
you
Yeah.
know, and even if they have a classic presentation, I don't make it until I've done an exhaustive search for a primary cause. It's just my bent on things.
Yes, it's that's why finally there was in MRI we look after some specific pathologies. But when the first time the radiologist didn't saw something very important, they describe only maybe even if the MRI was not dedicated to hydrop sequences, he noticed that maybe there is a kind of specific image on the left side, not on the right side.
Mm-hmm.
So the radiologist considered the imagery normal. Uh, okay, so however,
Can we go back to the MRI again,
I'd
please?
say this is
yeah,
definitely
Yeah.
not normal. I'm going to state something that Eugene, I'm sure you've just taken for granted, but this patient's got pretty significant atrophy. I mean, it's really
yeah,
big atrophy.
yeah,
Look at all the CSF in the posterior fossa. That's not normal.
yeah,
Mm-hmm.
The big, ventricular system. I think, I mean, because this scan was done in 17 and the original was done was it 15 or
no, 2017.
17? But the CAT scan, when was that one done? That was in
The scan was in 2015.
Okay. So it almost looks a little bit more impressive than the
Yeah,
original. Yeah.
I am.
Yeah,
Yes, definitely.
I'm not impressed with the atrophy on this first CT, actually.
Yes, but when you look at and he was right, Gerard, because even we are not the very best. No, I should should look to the. But I haven't here these slides. The imagine on the frontal pole because here effectively it's very impressive
What
and the left and the
the
top.
Mo, look at the middle scan for the CAT scan where you're seeing the posterior fossa and compare the amount of CSF there versus the one 2 years later. I think there's
Yeah.
progression.
Yeah.
And to the point where this may have nothing to do with the lady's vertigo problems, but it would make me want to
But
send neurology to figure out why is she having so much cortical and cerebellar atrophy, and there may not be anything they can do about it, but at the same time too, I would definitely have that evaluated.
Her vertebral artery is kind of shifted to the left side too, but I don't know. That might be it at the
yes,
moment.
the vertebral. Yeah, you're
Yeah,
right.
yeah, that
Right.
may be
On the right. Excuse me, on the
on
right.
the right. Yeah,
Yeah.
and
I agree. But Gerard, she had no. I saw it. Her. She had no any dynamic or static cerebellar signs.
okay. And
Okay.
your clinical exam, Eugene, no
Yes,
neurological.
I will arrive. Last, it was the examination for was
Um,
performed for a colleague, and he referred to us in our department, and effectively he just prescribed and he demanded some exams, some vestibular assessment and clinical evaluation subsequently. And he was the audiometry with the bone conduction verified in our department.
it's a better audiogram, I have to tell
Yeah,
you.
it's a better audiogram. Yes, I agree. And this was the findings on the vestibular assessment with the caloric tests and the cervical vamps. And I demand systematically also, even when the audiogram it's symmetric and there is no an impairment, unilateral impairment. I ask also for the brainstem auditory evoked response, and as we can see here on the right, there was a normal, quite normal pattern within interval between the waves correct for there was no argument in to support an eventual retrocochlear impairment. And as you see here, effectively on the right side, there was an ascending PTA with a more important deficit on the low frequencies. So, what is your feeling? What you do in this case? What and we look around. I don't was very convinced that I should look after again at the imagery, but it was the very first thought I had, and I start to look to the CT scan and after to the MRI. I think that it would be your position also. You try to search about something else, or do you just it was very interesting because Tanganil isoleucine is very you use it very much in France, and it's very a drug very uh, um, which gave globally a very good satisfaction when it's when we treat Meniere disease in crisis. But in this case, obviously, the patient didn't, the vestibular spelling was not very well responded, not at all at the Tanganel administration.
So he's asking, this patient is asking to stop those episodic attacks. Is that right? That's what
Yes.
he's asking. Well, I think
Yeah.
it's a good candidate for gent injection to the right ear. I would
Yes, I
strongly
also
consider
was
gent.
agree. I also was on the point to start the injections or to try again some Diamox, some diuretics, but I look more carefully, and I was if you I don't know if you can see my my
Yeah,
arrow.
I saw that osteo.
Yeah.
Still doesn't matter.
Yeah.
Because we are trying to stop the episode of vertigo. Or
Yeah.
are you going to operate this osteoma? Is it what you're planning to?
No, because generally there are not some very good results, and this resolution is not very good as a scanner
Yeah.
to put a diagnosis. But we came back and you start to relecturate the MRI, and effectively, when some special sequences performed by our colleagues, we discovered that was an important exostosis, at least it's no, if not osteoma, on the right side, but also, as you can see here, the eight cranial nerve was stretched at this level, but the imaging was both sides was there was osteomas on the both sides, but on the right side, there was even more important that on the left side, which was not impaired, and we were surprised. So in this case, we abandoned the idea to start to make a local treatment with gentamicin or dexamethasone. So we told to ourselves that it might be interesting to put a treatment, a neuroprotector, like in case of neurovascular cross compression syndrome, because this must be in our logic it's about a local neuropathy by compression, and then sometimes even in some cases of vestibular schwannoma, which is more or less important in dimension, it's when this patient have some important spelling or vestibular signs, we try to a neuroprotector before be more aggressive on a local treatment. And here is the results after putting her on the with an oxcarbamazepine for more than 7 years, and she didn't experience no more vertigo. And as you can see here, the audiogram, the successive controls was very well, and here in the right and on the bottom, this was the last control. It's a very good response to trileptal, not continuously. We tried to arrest the treatment each 6 months, but the patient was demand us after, because she experienced some vertigo spelling, and this why we have put it on trileptal with these doses, and with a very good result and a good biologic follow up. There was no problem and good tolerance to this medication.
Eugene,
Yes.
just a question. I think I read in there that she had a positional component to this, that when she would lay down, it would be worse. Is that the case?
Yes, but what from time to time, it was not systematically. When we tried to seek after and maybe on PPPV, but was negative.
All right,
Yeah.
so can you go back to
Yes.
the nice scans and just because one of the things when I look at these osteomas and some kind of retrocochlear compression of the eighth nerve, I really heavily rely on ABR results. And you got a nice normal ABR.
Yeah.
I'm wondering if this is not an intermittent traction injury, in that when she lays down and she's laying down on, for example, on your, actually go to the CAT scan. Where's the CAT scan? Oh, wait. Yeah, I wanted to see the CAT scan axial view.
This one?
Okay, well, the last one in the bottom right, I think. But if you look at it, it looks like in my mind, you've got a significant cerebellar atrophy. And
Yeah,
when he lays
this
flat on,
one.
what happens is the cerebellum floats down, and she gets the eighth nerve pulling on that exostosis more to where I think you're probably getting intermittent retrocochlear pathology from it. And that's probably over the years, every time it gets low. And which also makes sense that if you use Diamox in a case like that, it would probably, if anything, make it worse, not better.
But
It's
the sagittal, when we talk about cerebellar atrophy, I think the sagittal would be the best cut to look at.
yes, and coronal and sagittal. You're right. But and it deserves some, as in some pathology of the cervical spine, to have some dynamic
Sure,
imagery. But
sure.
it's
I almost wonder, this lady probably had that osteoma her entire life, and it was not an issue
yes,
Oh
until
yeah, absolutely.
the atrophy.
absolutely.
Yeah.
Absolutely, but I'm very glad if you raise this problem
Yeah.
about the possible mechanical issues in the internal and the at the level of the pontocerebellar angle and the cistern and the LCR cerebrospinal cistern at the base of the internal auditory canal, because effectively, if there is a maybe more or less important hyper pressure of the cerebrospinal spine, like in case of idiopathic hyperpressure, there will be a modification in the pressure between the position in upside position or in decubitus, and this may be exhibit an traction on the eighth cranial nerve,
You
and
know,
this could explain sometimes some spelling which is considered like central BPPV.
Yeah, I think the also you did the um, hyper, what do you call it when you breathe fast? Hyperventilation.
Ventilation.
Thank you.
Yes,
Hyperventilation.
hyperventilation test.
Yeah.
Yeah.
When you did the
Yeah.
hyperventilation test and she developed the nystagmus,
Yes.
I
Yes,
think it might
but
be
not that
thing.
was not was not stable. From time to time, I can observe at hyperventilation test some irritative nystagmus. I called him irritative because those were horizontal beating, right horizontal beating nystagmus.
I would say that the term vestibular paroxysmia is probably fits her. She has some tortuosity of her posterior circulation, and when you gave her the anti-epileptic medications, I mean, it could be vascular. But the important thing is, how do we explain the improvement in her hearing in this situation?
Yeah.
I think that we can kind of, as in a vestibular paroxysmia, we can observe from time to time, I think, two-thirds of cases, some modification on the interval between the first and third peak. Superior as the criteria of Muller, superior to 2.3 milliseconds. But the auditory nerve is more powerful. There are many fibers, and that's why I think even in case of compression, you didn't have an allongement of the interval 1-3. Instead, the vestibular nerve is very thin. It's a nerve which approximately two-thirds less fibers than the auditory nerve. That explains why sometimes the ABR could be perfectly normal in case of clinical suspicion of vestibular paroxysmia or you know. But this
Makes
hypothesis
sense.
is very, I think, is very clear, very important to have in mind this eventuality. And that because Mohamed speak about it, that guys and Gerald knows that now 2 or 3 years ago, I present before the Autoneurological Society, American Neurological Society, a paper with the near narrowed internal auditory canal, and these are the conclusion. But we can get together to discuss that. But I would like to show some other cases similar but not quite. And you see here even a hyperostosis of the temporal bone could lead to a narrowing of the internal canal, and this was a case which was presented as with the as a vestibular paroxysmia, and secondly, I had some as we published, as I told you, in 2023. I had some similar patient, but with an internal auditory canal which is inferior to 3 millimeters, and in this case, we can expect they have some dizziness or vertigo when lying in the bed, when they with the physical exertion, you know. So I think that we can stress that effectively we can observe that as a conclusion that some processes of at the internal auditory canal may mimic sometimes a Meniere disease or vestibular paroxysmia. I didn't put it here, but the discussion led to this. And I think that imagery is important to see and to re-demand in cases of Meniere disease which not respond to the specific therapy as in case of Meniere disease.
Eugene, correct me if I'm wrong, but I would probably lump this into the category of vestibular paroxysmia as well. I mean, it's just a different, cause for compression. It's not the vascular compression, but a bony compression. Is that not correct?
Yes, you're right. But what was atypical for this case, it was an impressive amelioration of the auditory, the hearing loss,
Yeah, the hearing
which
loss.
is not quite present in vestibular paroxysmia.
I mean, I'm gonna disagree with all of you. I mean, I disagree all of you. I don't think this is. I think if you go back to your tests, can we see your ABRs on there? So if you look at more carefully the tests done in your office, the ones that properly done tests.
Here.
Yes, in here. So I can't see it well even with this. So can you go over the ABR for us? For example, are the timings are same on the right and left and they
Yes.
do that
Yes,
500
it's
click?
quite. I will diminish because I don't see here. Yes, the interval, 1-5 interval on the right was 408. On the left, 404.
Okay, so nothing significant on that part.
No, no.
And in here, what I see mostly is normal at the 1000.
Yes, you mean on the PTA?
Yes, on the pure tone is the,
Yeah,
yes, there's a 1000 and 2000 are normal, but it's like a reverse, it's like
on
a speed
the
slope up and down
yeah,
on that part. And
yeah.
your vamps are perfectly normal in both sides.
Yes, they are normal.
And then on the CT, what majorly on the MRI, what we see is some atrophy and ventricular dilation. Is that right? That's what we get in.
Here,
And
yeah.
even in the first one, in the posterior occipital area, you can see some on your first slide. You can
Yes,
see on the generalized on there.
yes,
Yeah.
here.
So to me, I mean, if you put anyone with these symptoms, if you put the oxcarbazepine, you will have a improvement on the dizzy spells. Do you have any exams after that? Did you put the colorics again, or did you look at it with the goggles again in your office?
Yes, 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 because the patient it's still follow up in every
Yeah,
year
yeah,
in our department.
yeah, yeah. Have you
And
are you he's gonna be on the oxcarbazepine rest of his life or her life?
we try to stop each
And what happens?
and she was a little bit afraid that the symptoms not came back, and even if we didn't notice vestibular or nystagmus, etc. We being sure that the biologic profile it's okay and she tolerate very well the drug. But she's still under this medication. But we try to explain her that it's maybe because even the doses are not very important, and this as for the vestibular paroxysmia, you will see here I put it. She had one
150 evident trial.
and yes, the morning and in the and for night. So total doses of 300 milligrams a day.
Yeah.
Well, I think this is a great example of which is I'm a firm believer when you're dealing with someone with a chronic vestibular disorder, you need MRI scan, but you also need CT scan. I think with
Mhm.
you need both of them for someone with a chronic vestibulopathy, because otherwise you're just seeing part of the anatomy, and we've got the ability to see more of it. And I think this is a great example of why you need that.
Yes, and I would even go further and say if that patient was not uh, kind of investigated that much, they probably would have had either Dex or gentamicin way before any other treatment.
Yeah, definitely, because
Yes,
everybody told us about why you looking after something else because the profile,
I've
audiologic
I've seen
profile.
I've seen that happening, but
For
um,
somebody in her situation where she's elderly and she's, getting this cortical atrophy, and to lose the rest of her vestibular function on that side, is certainly, I think,
yeah,
worse result than what you got for her. I think you did a great job. I still don't quite understand the auditory
Yes.
But the vestibular certainly makes a lot of sense to me.
Yes,
That was a great case. Just a kind of a general question. If you, let's say it's Meniere's and you're going to inject, what's your first option? And I
in
think
Meniere disease, if we
Violent also made that comment. Yeah, do you use gentamicin or do you use dexamethasone?
no, I try even more. I put a transtympanic drain, and I wait sometimes because in our experience, some patients ameliorate with no
Wow.
other local therapy. And after that, we try some 4 or 5 installation of dexamethasone or derivatives or steroids.
Yeah.
What is it you're using? I'm sorry, amyloid? What was the medicine you're using? Sorry.
And we said it could ameliorate the symptoms.
Oh, okay. I
In
see.
other words,
Yeah.
he's
I
fixed
mean,
the patient.
ventilate. Yeah, I know in Europe, a lot of people use PE tubes to first line of therapy for Meniere's disease. Even we still
Yes,
we don't we still don't know the full story about Meniere's anyway. And the Dex.
no.
Yeah.
I either don't understand what's happened with some patient, but I think that we have some 30 or 40% that ameliorate with no other
The,
medical treatment,
the,
local treatment.
this patient didn't have migraine in her history.
No. I search after.
No, of course I do. I'm sure, but I just wanted to make sure about that. Yeah. And if you decide to use dexamethasone, what dose do you usually use?
Dexamethasone. I think that we used some for 20 milligrams. There was not very much doses.
Yeah.
In case of there are some colleagues which use even Medrol, but
Yeah. Well,
high
uh,
doses. But I
yeah.
don't think that because it's very painful for the patient if the steroid that's concentrate, they have more pains in the ear after the administration of the drug when compared to, for example, with the Gentalin.
One little trick for that, Eugene, is just to add a tiny bit
Yes,
of
buffering. Yeah,
a,
buffer. Excuse me, buffer the solution. Yeah.
Yeah.
a tenth of 1 to 10 lidocaine in there.
I think
Lidocaine. Okay.
the dexamethasone is the only one that actually crosses the stria vascularis barrier, but we'll talk about that at some point. We should get uh, blocking on his name from Canada, Art Lauren
Oh,
Pond.
Lawrence Bourne,
Yeah,
Barnes.
Yeah.
Lauren Parnes, yeah,
yes.
from London.
Yeah, he and I went into extended discussions about which medication based on his study is phenomenal, actually, I have to say.
Yeah,
But
it's one of the largest.
we'll talk about that in the pharmacological treatment of the inner ear. That was a great case, Eugene. Thank you.
Yeah.
Excellent.
I wouldn't do the gentamicin on this one too, because I didn't realize that the hearing normal at the 1000 and 2000. If I gonna do IT, I would have done dexamethasone. I
Yeah.
usually 3 of those, and we have only 10 ml ones available and commercially, although you can have them prepared sterile 24, but it's kind of a big, it's not the
I think the commercially available one is the 4
10.
milligram per mil and a 2 mil
No, 10. 10.
We can get 10. Yeah.
And then I don't disagree with your medical treatment too. I would do the same thing, but I think I disagree with this. This is anything to do with the osteoma. I think this is something to do overall what we see on the MRI with some, I would call it megalomegaly, some atrophy, and as long as it works, it's fine with us. I mean, too. So, but I take it back. So I won't inject gentamicin. If I do a gentamicin, I usually do single injection, and I don't buffer. I just put it in there.
I don't buffer either. Yeah, most patients do well with it. Yeah. And if you use one or two injections and they don't have the proverbial sensitivity to aminoglycosides, you don't really see any major hearing loss with gentamicin.
The point's made that in a 75-year-old patient who's got cerebellar atrophy, it's really, really dicey, because they're going to have to, if you cause any damage, maybe you can stabilize them, but they have to recompensate for the new situation after you've hit them in gentamicin. So maybe Dex would be better first.
Yes, there was no criteria finally. Even this atrophy was present, but it's an image. But I recall you guys that I perform cerebellar, very attentive cerebellar, the dynamic and static probes, examination, and there was no signs of affected of the coordination or similar problems. But I agree with the person which now she had 80 years old, who must avoid to induce an hyporeflexia or narreflexia, and should try, even if it's a more complex that than the osteoma. We must try an approach step by step. We does not do it and induce an areflexia, because these kind of subjects are very fragile, and you must avoid fragilization more than that.
I was going to add, the older I get, the more conservative I get in try to avoid, deafferentation. And the point I was going to make about your your cerebellar exam, I'm sure it was normal, but the thing is, it's normal.
Yeah.
Now.
Okay.
Years, I'm watching that cerebellum get smaller, and I'm thinking to myself, I really would not want to remove her.
No, they compensate very, very quick. Yes, I know, but it may be they want not a dilatation of the lateral ventricles, but in case of this kind of subjects with these images, there is clear that it's a risk of decompensation very quick, and dilatation as they could become cerebral or very. I'm agreed of all of you.
Well, thank you very much for the invitation. I really enjoy your presentation. Thank you again.
Thank you very much for your commentary, because we must discuss and in opposite there is a progress after. Ideas, the big ideas from here. And I must stress the idea of Gerard, and I think that in the future some relationship between the more or less idiopathic and intracranial pressure we discussed, so the Mohamed. We discussed already this way of yes.
As I say, Bulent's got a strong interest in intracranial pressure.
Oh, okay, but so it's very interesting. We should discuss this subject, because I think it's really important.
And it's still under-recognized, I would say.
Yeah.
Gerard, why did you think that Diamax will gonna make this patient's symptoms worse? Would you re-explain it?
Yeah, I think if you lower her intracranial pressure, I think the brain's going to sag, put more tension on the nerve.
Oh, the ventricular thing is going to nerve. Okay, I see.
It's the same reason.
Even if in the cistern of the base in the pontocerebellar area, they will diminuate in volume, and this will add to the constraint and mechanical constraint developed by the osteoma or by exostoma. And there was also a little angulation of the nerve that it was like a kind of pulley, you know, in mechanics. That I think that, yeah.
I was going to say the other reason I was thinking it would make it worse is because I've done it before. I made a
Well,
I see.
the other thing really is how much Diamox. I think you need pretty high dose before you get to some of these compromises as well.
What about Chiari? Do you guys use Diamox in Chiari patients?
I do.
What?
Yeah.
Yeah.
Because I think the primary pathology in type 1 Chiaris is increased intracranial pressure. And if you
An obstacle, yeah, on the
you help with the descent or the cerebellar ectopia part of it.
Yes, at the same time, we must take care about the amygdala, cerebellar amygdala, because they will advance to, they
Down
will
in the
push
spine.
down. It's not a very good. I'm very precautious in case of that. Fortunately, they are the neurologists with will deal with this.
Well, we should send them to neurosurgery.
Yes, right.
Yes. So Jerry, next meeting would be on pharmacology of treating inner ear disorders.
Well, I think Art going to be doing a case.
Oh,
Well,
Yes.
if you want me to, I was thinking I'll send you a couple of suggestions in the next week or so, Jerry, and maybe a case report or a combination of similar case reports or something. Would that be appropriate?
I think that sounds great. You know, knowing
Okay.
this group, all you need is one simple case report, and we'll talk about it for a while.
Yeah.
Oh, okay. I'll
out here on the schedule is Friday, October 17th would be our
okay.
next.
Okay.
And
Okay for me.
join us next time. Enjoyed your input.
Yep.
Yes.
All right. That was fun. Thank you.
Okay.
Thank
Oh,
you.
it was great.
Thank
I'll send you a
you.
couple of things in a week or so, Jerry. That's great.
Okay.
Thanks a lot, Eugene.
See you in back home in Louisiana.
Yes, sir.
You're
Yes, sir.
coming too, all of you.
What's
So
that?
Yes.
Gerard has a big presentation there, so I'm very excited to listen.
Well, good deal.
All right then. Thank you all.
See you
Thank
guys next time.
Okay.
Was
Okay
pleasure.
then.
Thank
Okay.
you.
Bye-bye.